As I said. I haven't seen that one before. I'm Janet Barron, the Executive Director of Northwest Health Law Advocates, NoHLA, an organization dedicated to improving access to healthcare and achieving equity for Washington residents. We use our voice to advance health as a human right, and we raise up the concerns and barriers that many in our state are facing when they seek care. I'm so pleased to introduce our presenter for today, Anne Vining, staff attorney at NoHLA. Anne's work at NoHLA builds on over 35 years representing low-income clients as a legal aid lawyer. She's an expert on public health programs and services that are available to elders and individuals with disabilities. And she's been spending the last 2 years researching and considering options for improvements in coverage for those with Medicare who have limited income and who lose more comprehensive coverage when they turn 65 or become disabled. We're grateful for the generous support from the Pacific Hospital Public Development Authority, PHPDA, which makes this work possible. Anne, I turn it over to you.
Well, thank you. This is an introduction to what's been called the Medicare Cliff. And it's going to start by talking about what that refers to, what that means. Then we're going to talk exactly how Medicare is not affordable for many low and moderate income people, and what Washington could do about this issue. So please put questions in the chat box. Emily's going to call to my attention anything that requires clarifying right away. But we'll look at broader questions and comments after I go through the presentation, which will probably take a little over 20 minutes, 25 minutes. So I don't see the screen share anymore.
Are you ready to go?
Yes, I'm ready to go. Thank you, Hafik. All right, so the Medicare Cliff refers to the big drop in coverage and subsidies for healthcare costs that many lower income people experience after they start on Medicare compared to assistance they got from Affordable Care Act programs before Medicare began. Next slide, please. The result is the thing that grabs me every time. It's a big piece of the pie, this healthcare cost. Half of Medicare enrollees with income 200% of poverty and below reported spending 27% or more of their income on healthcare. Think about that, 27%. This is people who have a little less than $2,200 a month to live on. And that's the thing about Medicare. The expenses that you're going to have really depends on your health status, your problems, your health problems. But the costs are the same whether you have 200% of the federal poverty level or $200,000 a year of income. Women and people in racial and ethnic minority groups are disproportionately affected because they are disproportionately low income. Next slide, please. We're going to look at a couple of examples of how this works. We'll call this woman Martha. You can see she makes just a little over 100% of the federal poverty level. And she has resources that this is her life savings, stashed away money while she was working. This is what she's got to protect her from unexpected expenses for the rest of her life. And she does have some health conditions. Next slide, please. So this shows what happens to her. Before she turns 65, when she's 64, she qualifies to get the Medicaid program provided by the Affordable Care Act. This is the new program. Many people call it Obamacare. Before that, you had to be in a special category in order to get Medicaid. And one of those initial categories was people that are age 65 and older, or who have permanent disabilities and have been on Social Security disability benefits for 2 years. So that group, when she turns 65, all of a sudden she's no longer eligible for Medicaid because that program's only for people who do not have Medicare. But she doesn't qualify for any assistance program after Medicare begins. There's no Medicaid. The Medicaid that's available for people that are 65 is age blind disabled, sometimes called SSI related. And she's also not eligible for any of the Medicare savings programs. Her income might be low enough, but her savings is too high. She gets a partial low income subsidy program that helps with her prescription costs, but that's it. The bottom line is, instead of having all of her income for rent, food, transportation, other costs, now she's got $867 a month for those expenses. And she spends $320 on uncovered services, cost sharing. There's no cost cap. Next slide, please. Jorge presents a similar example, except he's a little higher income, 156% of the federal poverty level. And he has a little bit more savings, but he has a lot more health problems. Next slide. When he's 64, his income's too high to get the Affordable Care Act Medicaid program, but he can buy a health plan, qualified health plan on the exchange and get Affordable Care Act subsidies, tax credit for the premiums, and he also gets some cost sharing relief. It still leaves him with a fair amount of out-of-pocket expenses, and he maxes that out. So that leaves him with 12% of his income for healthcare expenses. When Medicare begins, he's no longer eligible for the Affordable Care Act programs. He's also not eligible for any of the age blind disabled programs, the program for Medicaid, Medicare savings programs, or even for prescription assistance. He's too wealthy for that at 156% of poverty. So he's going to spend $452 a month for his health costs. There's no cost cap. Next slide. Uh-oh, go back. Oh, there it is. Okay. A lot of times people ask me, well, wait a minute, isn't Medicare free? And I think that people think that because you can get Part A, which is basically hospital and in a limited amount of skilled nursing facility, acute level care. You can get it without paying that premium if you have enough work quarters. It's roughly 10 years worth. If you don't, which happens a lot to more recent immigrants who haven't worked 10 years before they're of retirement age, you can pay up to $471 a month. Otherwise, that's subsidized, but that's it. And that's not the only cost. I'm not going to go through all of these, but there are deductibles. There is coinsurance. Part B, which covers all of the outpatient costs and doctors' tests, the x-rays, radiology, all of that stuff. Even if you're in the hospital, those are covered by Part B, not by Part A. And so you have to enroll. You have a pretty hefty premium, $148.50 a month, whether you're at 200% of poverty or $200,000 a year. There is a higher amount for higher income people, but it's still a big chunk when you're at the lower income bracket. And then there's the 20% cost sharing, which you can address by purchasing supplemental coverage, but that coverage is fairly expensive too. Again, if you have $200,000 a year, you will find that it's manageable. If you've got 200% of the federal poverty level with the same expenses, it's really not. Then none of those cover outpatient prescriptions. That's Part D. You have to enroll. You may have premiums. You may have copays, coinsurance. At a certain point, you'll fall into what they call the gap, where you pay 25% of the retail cost for the prescriptions and their formulary limits. The only way that people can cap the out-of-pocket costs is to qualify for a needs-based government program called low-income subsidy, LIS, or it's also sometimes called extra help. Next slide. So what about needs-based government assistance programs? Can't people just get on Medicaid? I hear that a lot too. And indeed, Medicaid and Medicare savings programs can help protect people from costs. Those programs provide affordability by paying those Part D premiums. And believe me, I have people who have moved from apartment into shared housing to save less money than the cost of those Part B premiums. They also, if you qualify for any of those, you automatically are eligible for the low-income subsidy program, covering your prescription costs or helping to reduce your prescription costs. But only Medicaid and one of the Medicare savings programs called QMB, and it's only for people at 100% of poverty and below in Washington. Those are the ones that can address the cost sharing and the deductible, those out-of-pocket expenses. Next slide. Now, none of the Medicare savings programs, not even QMB, only Medicaid adds services that are not covered by Medicare. You know, we're hearing that there's proposals to add some services to Medicare. And different states have different lists of services, optional services that they cover in their Medicaid programs. In Washington, some of the things that Medicaid adds to people with Medicare are routine dental care, hearing aids, routine vision exams, transportation to medical appointments, even when it's not an emergency, and so on. Next slide. This is a little chart. I know that some people, especially people with a lot of significant chronic conditions that require very expensive medications. I mean, think rheumatoid arthritis, think cancer, a lot of different people with hepatitis. The co-payments, you can see the income is pretty limited. These are the federal standards, and this is what our state uses. At 135% of poverty, you're to have too much income. You've also got to have limited assets. But even if you fall into those categories, you may have co-payments. Look at that little chart up in the top right, 15%. And even if you hit over $6,500 in out-of-pocket costs, you're still going to pay something, and you could pay 5% of the drug cost. Well, 5% of very expensive drugs is still a significant amount of change, especially since by definition, you're already low income and low resources. There's a way out of that, and that's the bottom chart. If you qualify for Medicare or and Medicaid, or you also qualify for a Medicare savings program, you go into this box and you can see there's on the co-payments, none of those 15%, 5%, none of those apply. And I've been talking recently with some pharmacy sections of insurance, an insurance company that serves this population, and they're concerned because they all the time see people who simply can't afford to fill prescriptions that they need. Next slide. Just a rundown on what these income limits are. And in Washington State, the top part of this chart is people that have Medicare. So they don't qualify for the Affordable Care Act programs. They only qualify for these older programs that weren't changed by the Affordable Care Act. You've got to have income of 75% of the poverty limit, which is $814 a month, which actually includes a $20 disregard that applies to these. But that's the number. 814 is your amount to get Medicaid. If you are going to get the Medicare Savings Program that includes both paying your premium and addressing your cost sharing, just for things that are covered by Medicare, so not dental, vision, or whatever, your limit is 100% of poverty, and that's the number, $1,094 a month. Next lower item there is getting premium only coverage from one of the other Medicare savings programs. There's SLMB and ESLMB, or sometimes called QI1, but the max is 135% of poverty, and that's the number there, 1,469. So contrast that, keep going down, and here are the same categories of assistance that are available to people under the Affordable Care Act who don't have Medicare. Look at that. 138% of poverty. That's higher than any assistance program available once you're on Medicare. You're eligible for Medicaid. And you can get premium and cost sharing subsidies up to 250% of poverty. You can get premium only subsidies. It used to be up to 400% of poverty, and now under the latest COVID Relief Act, COVID relief bill, the ARP Act, a few months ago, that ceiling of 400% has been lifted because it's been recognized that it wasn't affordable. And so now people, even with income higher than that, pay a maximum of 8.5% of their income for premiums. It's supposedly only for this year and next year, but there's a lot of work at the federal level to extend that. Next slide, please. So the next question I hear a lot is, well, how much do people really need to live on? And there's actually some very good resources for this. The Elder Index is a tool that the Gerontology Institute started some years ago, and it's a measure of the income that older adults need to meet their basic needs and to age in place with dignity. That's the idea. It's specific to household size, location, housing status, what kind of housing cost status you have, and health status. And it drills down in location, not only to state, but to county. So it's based on the cost of housing, healthcare, transportation, food, and miscellaneous essentials, which include things like supplies and paper products, phone service, things like that. No gifts, no entertainment, just a very basic budget. And here's what it is. In Washington State, the two variables that really make a difference are whether you own and have a mortgage, whether you rent, whether you own your housing and have no mortgage. So housing. The other big variable is your healthcare status. Do you have poor health, good health, or excellent health? And the figures there are showing. Next slide. Here's some totals. In Washington State, for those three categories, the total monthly amount that people need to pay for those things is this. In King County, as you might expect, it's a little higher. And in Snohomish County, it's also a little higher. So income standards like $814 do not get you enough money even before you pay, for any kind of health costs. You don't have enough money to live on with a decent, secure income. Next slide. Well, it turns out there is something states could do about this. There's something Washington could do about this. Federal law allows states to expand Medicaid and Medicare savings programs by raising these income and resource limits. If states do that, federal funding shares the cost. They don't completely pay for it. The state will have a share. So out of the 50 states plus District of Columbia, 34 states and the District of Columbia have expanded eligibility in some way. Nobody's got parity with what's available under the Affordable Care Act, but for everything. But most states have done something. A lot of them did this decades ago. They raised Medicaid to 100% of poverty, or they eliminated resource limits. A lot of different things have happened. Washington has not done anything. We use the federal minimums that are allowed by the programs without any expansion. Next slide. So what could we do? Well, we could completely change this. The column on the left represents income limits going up for income higher and what programs are available. The bottom is Medicaid. That's the most benefit. That goes up to 138% of poverty. The next one is qualified health plans with cost sharing and premium subsidies up to 250% of poverty. And then QHP premium subsidies only, which goes up to 400%, except really it goes up way higher now. The middle column is what's available to people with Medicare. Medicaid stops, the purple stops at 75% of poverty, about. A little bit higher, up to 100%, you can get cost sharing and premium subsidies. And then you can get premium subsidies up to 135%. What could Washington do? Washington could change all those categories to make it comparable. That is within the state's power. Next slide. There's also an option to eliminate resource limits. The Affordable Care Act programs have no resource limit. None. Of course, if you have more resources, you tend to have income resulting from those resources. So it gets counted on the income side, what you're eligible for. But you're not disqualified because you've got a $10,000 IRA. People on Medicare have very restrictive income resource limits, savings limits. It's something that's not exempt, like one vehicle and a home, equity in your home, then you are restricted to $2,000 or $3,000 if you're a married couple. So that's pretty restrictive. That's what's required for Medicaid. It's a little higher for the Medicare savings programs, and it's a little higher still for the low income subsidy, but it's a pretty big disparity. And the problem is having any resource limit at all is a barrier to people getting on the program. We know from decades of research that the Medicare savings programs are under enrolled, that there are many more people who are eligible than enroll in it. They don't know about it. It's too much of a hassle. They can't deal with all the paperwork. And a big factor is when you have a resource limit, you have to disclose all of your resources and provide proof of the values. So that's a barrier to people. And then the state has to use its resources to investigate these and determine whether They have verification for everything they need. What are the values, and is the person eligible? So resource limits are a barrier, and it's probably why a number of states have eliminated those for at least some programs. Next slide, please. Next question you hear is, well, what would this cost? Well, the answer is really, we don't know. NoHLA has asked the healthcare authority for data that we would need to start looking at this issue, and we've been pretty much shut down during the pandemic. We're going to try again, but we know what the categories are. So to expand Medicaid eligibility, being eligible for Medicaid would give people, would require the state to pay half of the Part B premium. That's assuming the person is within the limits of a Medicare savings programs. Now, some of those people may not be new. They may already be getting a Medicare savings program. It depends on what the proposal is to expand to. But for services that Medicare covers, we don't think that the state pays very much. Our state has chosen, instead of paying that 20%, they only pay if the amount Medicare's already paid is less than the state's Medicaid rate for the service. And if Medicare's already paid as much as the state would pay for a Medicaid patient, then they don't pay anything more. It becomes a provider write-off, and the client doesn't get billed. So how much does the state actually pay for those services? We don't know, but we suspect it's fairly low. But then there are services that being on Medicaid would give you that you don't get under Medicare. That's that dental, vision, all of that stuff. The state would pay half of the cost of that at their rates. The feds would cover the other half. What about expansions of QMB and the other Medicare savings programs, if that were the proposal? Well, they would pay half of the Part B premium cost. And again, the cost sharing for the Medicare covered expenses is usually quote unquote covered by a provider write-off. Now, there may be some providers that wouldn't be too happy about that, but that's how it works. And that's how people are served when they're on these programs. Next slide, please. I'm not going to spend a lot of time on these, but these charts, you'll see these in your PowerPoint. These charts show what Washington's doing, which is the federal minimums. Down below, it shows what some other states have done. For example, on income limits, 24 states and Washington, D.C. use at least 100% of the federal poverty level for their Medicaid program for age, blind, and disabled people. And California even uses the same that the Affordable Care Act standard is, 138%. That started, December of 2020. Resource limits, there are, I've got a little cat blocking what I'm looking at. So this has been less done, but a number of states have done it, that have raised those resource limits to something higher than this limit that hasn't changed since 1989, 2000, 3000. Arizona has no resource limit. Next slide, please. So here's some options for the Medicare savings program, and we're focusing on QMB because the main cost to the state is from people newly having coverage for their premiums. That's the main cost when you expand Medicare savings programs. So what's the point of doing that and then not offering the cost sharing? So QMB, you see what we're doing, 100% of poverty. Some states have raised that limit. A number of states have eliminated resource tests. And they've benefited by not having all of those costs for processing applications. Next slide, please. And it's not like these are old hat. A lot of these things were done a decade or two ago, a lot of these expansions, but Massachusetts, a bunch of the Mass Senior Action group got together and really did a campaign on this. And as of last year, they expanded Medicare savings programs to cover 40,000 more seniors. Next slide, please. Another question I hear is, well, what about the pandemic? What about pandemic relief? Well, they did cover testing for everybody, but the relief that you hear about was mainly premium subsidies, changes in the subsidies that are available to people with Affordable Care Act programs. There was nothing changed for Medicare. Next slide. And yet, funny thing, the pandemic has had a disproportionate effect on older adults and people with complex health conditions. Doesn't that sound a lot like the Medicare population? Most of the deaths and most of the hospitalizations are people in these categories. And Medicare enrollees with the highest rates of cases and hospitalizations are people in these minority communities listed here. Next slide, please. So the summary really is, the takeaway is that our current Medicare program is neither as comprehensive or affordable for people with low and moderate income as it could be. Washington State could address this regardless of whether anything happens in the federal level on Medicare or coverage. The only thing I've heard about is adding some services to coverage. I really haven't heard of any affordability issues other than price, possibility of price controls for the cost of medications. Not clear how that would translate to affordability for the senior or the person on Medicare. We have links in here to our more detailed report, a lot of research there, a lot of other information, and you'll get a follow-up email with this, or actually I think Afik already sent it out this morning. So NoHLA's been researching this Medicare unaffordability problem, and we have developed a lot of information. What we're doing now is we're considering next steps to address the issues and evaluating whether organizations are interested in working towards solutions. So please let us know. Are you part of an organization that may have such an interest? You can let us know in the chat. We'll save that, or you can email us afterwards or give us feedback at the link here. And please do continue to send us stories about people on Medicare who are struggling with affordability. We need to hear those details. Next slide, please. Thank you very much. So we have a bunch of questions in the chat.
We do not have any questions in the chat, so please feel free to join in, everybody. And thank you, Judith, for the remark about Sheba.
Hi, Judith. Judith is with the Office of the Insurance Commissioner's Sheba program, and they kind of know a lot about this subject.
Okay, I know someone out there has a question about what QMB is and SLMB, and please feel free to go back to basics, even though Ann did an excellent job explaining all this terminology. So folks, do feel free to jump in.
This is Janice. Hi, thanks, Ann, for that. I just want to jump in and make a comment that during, because we're still under the emergency, individuals who came on to Medicare during this emergency this year, I don't know what happened last year, are still receiving, or they automatically rolled into QMB and self-help. Is that what it's called? I think it's called self-help, whatever, no, whatever, extra help, right? So they automatically rolled into there, but I don't know how long, I think in October when they reapply and they find out, they might have more assets, like some of your examples, then they'll have to start paying Medicare that they're not currently paying, right?
Is a huge problem. There is a huge problem in that, it's great that people kept their Medicaid during the pandemic and didn't get thrown off and, have to deal with all the affordability issues. But on the other hand, by not transitioning, they may have failed to enroll in Part B. They may have not taken advantage of getting a Medicare supplement policy, which if they have high health costs, in the long run is going to be cheaper for them than a Medicare Advantage plan. And later they would have to have underwriting, medical underwriting to get into those plans. So if you already have a lot of health conditions, that's not very likely. And I know the Sheba volunteers are seeing concerns about this, and we don't know exactly what's going to happen. There are things that could be done to make this transition easier, but it is a little bit of a nightmare to think about all these people who would have fallen off the cliff during the pandemic are going to all fall off at once when it's over.
Some people, if they've applied for other, I heard this from a DSHS person, and I don't know how valid it is, but I think it is, that if some people have applied for some other benefits or something, and they have, attested to their whatever they have, then they can get tossed off, right? So it just depends what happens. So if you say it's because it is different than the Affordable Care Act or whatever, if they've applied for just any other kind of state benefits, that it could, then all your information pops up, and then they might not be on the extra help in the QMB anymore.
Thanks so much, Janice, for that. That's really helpful. And I see we have some questions in the chat and hands up. So why don't I suggest that we first answer questions that have come up in the chat about what is Sheba and how does someone get help from Sheba? So let's answer that first. Then let's go to Zach, who has a question, and next we'll take Diana's question. So first up, Anne, what is Sheba? And if you and Judith or anybody else wants to explain how to get help from Sheba. Oh, looks like we've got some information.
Well, Judith has a little note that says we have Sheba staff and volunteers. It's a program run through the Office of Insurance Commissioner. I don't know if all states have this. Most number of states do. Our program's run by the OIC, and they partner with entities in local areas, and they recruit the volunteers, and there's extensive training and support for the volunteers and the staff. And they do advising to people who are making this transition. In different areas, it's housed in different entities. So if you go on the website for the Office of Insurance Commissioner, there's a toll-free number. Maybe Judith has it.
Yeah. Can you hear me, Ann?
I can.
Yeah. Every state and 4 territories have a SHIP program. And for anybody who is on any part of Medicare, they get the, I don't think my video is on, but they get the Medicare and You Handbook every year, and their state or territory's SHIP 800 number is on the back, because every state has its own jurisdiction over Medicare supplements, and we're funded by the state and as by the insurance commissioner and the federal government. And every day we screen and help people enroll into the extra help in the Medicare Savings Program. We partner with our Medicaid agency, the Healthcare Authority. And so, yeah, we live and breathe this every day. We assist people getting ready for Medicare, their caregivers, their family members. And we service Medicare throughout the years, all the way through to hospice. And we help people that call and say, my wife died and I'm still getting bills. And I think the funeral home let Social Security know that she passed away. What do I do? So, yeah.
Absolutely. We couldn't do without it. So when you're facing those kind of things, that's a really great source of information.
Thanks. So
And Zach, do you have a question?
Yeah, hey, thank you for taking my question, and thanks for the presentation today and the report and all the work that the organization's doing on this issue. So I read the report, and one of the things that stuck out to me is the data showing that if the state of Washington were to remove the resource or asset limitations and expand income eligibility to like 300% for the QMB program and 400% for the other program, that it would open up maybe up to 347,000 people to have eligibility for the program. In doing that research, did you come across the cost to the state that would incur? Because you said there's like a 50% match. I don't know exactly how the state portion of this is funded. I'm curious if you came across that or did any work on that. Thanks.
Well, like I say, we did a public disclosure request for data to the Healthcare Authority, last fall, and finally got a response during the legislative session that they did not have the resources to respond to it. So at that time, so we're still hopeful we'll get some of it, but really costing, the very most difficult thing is how many people that might be newly eligible would actually apply. And that's a difficult projection to make. And the other thing that's difficult is some of those people may already be, they would not be new because they're getting long-term care services. But in order to sort through what's the number really, that's a very complex task and more data would be needed to do that. But assuming you had some number, you had some basis for an assumption about the number of people, then you've got to look at, well, what would the costs be? Well, for Medicaid, part of the cost is going to include services that are not covered by Medicare. So we need to know what's a kind of a per member per month for existing population for those services, and we haven't been able to get that. We also haven't been able to get what happens on the Medicare Savings Program side with how much are you, in theory, our guess is they're not paying very much towards that 20% cost share that applies to Part B. But certainly there must be data about that cost, and we've not been able to get it. We're going to work on it. And but the other thing is what the data is really depends on what the proposal is you're talking about, because everything's a moving target. If you raise Medicare savings programs and Medicaid, then the implications for the cost for Medicaid may be different, may be smaller because you only have to pay 100% of the Medicaid covered persons Part B premium if they are not under the limit that your state uses for the Medicare savings programs. So it's a complex topic and we're not ready to come out with any figures. Hope that helps. Where are you, Zach? Are you, like you work on these issues?
Yeah, I do. So I'm Director of Government Affairs for Regents Blue Shield, and we're a health plan in the state. So these, expanding access to coverage issues are always really interesting for me. And the work that you all do is something I always want to pay attention to and follow. So I was just curious, looking at these different proposals, what that impact would be, and just sort of thinking about it from a policy perspective, So it's interesting, and I understand where you're coming from about the difficulty in nailing down a number, because sure, you could expand QMB to 300% and remove the asset limitation, but if you keep Medicaid at 75%, it's going to be a different cost than raising it up to 138 plus, the SLMB program and all these other things. So it's interesting. Did you come across how much the state is spending today on Medicare savings programs?
No, we haven't, but that might be easier for them to tell us than some of the pieces that we need to figure out, what might costs relate to. So it might be something that's available in the budget materials. Might be hard to find though, or to tease out.
So recognizing there are other questions in the chat, I think I can answer Diana's question quickly. Diana asked whether we're a member of the Senior Citizens Lobby or if we've reached out to AARP. And part of what we're doing in this webinar is reaching out to groups that might be interested in seeking partnership and solidarity on this issue. So thank you for those ideas, and welcome help reaching out to and making connections to groups that you think would be involved. So, Anne, unless anything further than that, I did want to go to John Kim's question, which was how much of the cliff can be avoided by really good planning before people reach Medicare age?
I don't think people can plan their way out of this. I mean, other than, pick a field of work that pays you well. And so you have as much savings and you have as much income in retirement as possible, maximize your Social Security income, maximize your savings. I mean, it just isn't possible for most people. Yes, some people do well, and there are people on Medicare that aren't struggling. Higher income people may consider it to be reasonable, especially if they do not have high health costs. But for lower income people, I mean, if they had the avenue to have more income and resources available to them in retirement, they would be better off. But I don't think they can really plan. It's like, what do you have at the end? That's what matters. Now, I think the choices people make on enrollment can make a big difference. But, I've talked to people who you can tell they're going to do better if they could have a Medicare savings plan. But if they're already struggling to figure out how they're going to pay that $148 a month, they certainly don't want to pay another $169 to $200 a month for a supplement plan. And they're probably going to think, well, I can get a Medicare Advantage plan with no premium or a low premium. And they're not looking at the high maximum out-of-pocket costs that they're going to have. And if they already have a lot of health expenses, that's really relevant. More questions?
Thank you. And let's take Kate White Tudor next from the chat. Would changing these income limits also change eligibility to Medicaid long-term care? And after that one, let's go to Tim and Janice. So again, would changing these income limits also change eligibility for Medicaid long-term care?
Well, the kinds of proposals that we've talked about would be for the non-institutional Medicaid program. But you're right, there is a wrinkle there, because a few years ago, Washington adopted Community First Choice, CFC, as our method of providing personal care services, which for people outside of nursing homes, that's the critical piece of a service that you need. And if if you have Medicaid, you qualify for that as a state plan Medicaid service, just like you would qualify to have a doctor bill paid. So that's a major function of the long-term care program, is providing that service, and it's no longer part of the institutional Medicaid programs. So that would be a factor. I mean, a cost to expand Medicaid would include that. Would point out, however, that if you are under age 65 and you're not on Medicare, you can get Medicaid at 138% of poverty with no limit on resources. And if you get that, you're already eligible for those programs. So yes, probably a higher percentage of older adults and people with chronic conditions are going to be higher cost. So hard to tease that out too, but this could be done without it becoming part of qualifying for institutional Medicaid or for the home and community-based waiver programs.
Thanks so much, Anne. Let's go to Tim Burns next, if you want to unmute.
All right, thank you. I appreciate this webinar. I am the chair of the Government Relations Committee for the Puget Sound Advocates for Retirement Action. And it kind of a follow-up to Diana's question. Is there specific legislation proposed? And if so, who is the prime sponsor? We could put it on our legislative agenda if we have something to support there.
So that question, it's not that far. That hasn't happened yet. There's no campaign leader. There's no legislative champion or a bill at this point. So it's a little bit earlier than that, but I'm glad you think it's something that your organization would support. That's really helpful to know. Anybody else?
Yeah, this is Janice.
And then Jackie Boschak from the chat after that.
Yeah, I just wanted to mention that when I came on to Medicare this year and I was debating staying with Kaiser or not, and I looked around, I was looking for Medicare Advantage. I think it would provide more, in some instances, it would provide more options that I prefer, right? But I just want to say what I did was I went in to eat, the different programs, community, Humana, whatever the different United, whatever the different programs were. And I looked at the drug formulary. I'm not on very many medications, and almost all of them they are all PRN. And I could not believe the difference in the pricing. So for people that are in, they do have a little bit of, I wasn't aware that, what would happen when I came in, but if you have some assets and you're not going to qualify for Medicaid or whatever, I wasn't sure, but it varied from the Medicare plan I chose to I only have to pay $15 to $350 to the community plan or the United plan and whatever, normally a $700 for eye drop, for another hormone. I mean, it's just ridiculous, the prices, right? So when I balanced it out, I realized I'd be paying more going through. And also they had most of them had a 20% copay, not a cap necessarily, a copay. And so I think that some individuals might just stay with who they're with and not really look around. And that's something I think that's super important. I expect Sheba does do that. I did talk to Sheba on a couple other things, but that's a really deciding factor if they are on medications.
Yes, that's absolutely huge. And this sense of, there are many people who are overwhelmed by all of those choices. One of the scariest things I read in the last 2 years was in February, there was a report of an economics group that found an innovative way to look at Medicare patients who fell into the gap and those who didn't in their first year. And what they discovered was a modest increase in the price of medications could make people just throw up their hands and stop filling any of their prescriptions. They didn't do this sort of rational calculating, well, which ones are the most central to my conditions, which, you know, they didn't go through that process because it's just too hard. So a substantial number of people simply just didn't get prescriptions that they needed, and they saw an increase in mortality.
Exactly. You know, something simple they could do in that is they didn't, I don't think, I'm not sure if any of them had an alphabetical. They do it by type of drug. And, you know, I'm fairly well versed on a lot of the, you know, drugs that are out there, and I couldn't figure it out. Right. So they're, you know, beta blockers or whatever. I mean, you know, they're much more extensive than that. So if if the plans were required to have an alphabetical list, then people could actually look it up. It's huge though. The list is humongous, right? But it's way too, like, it's, you know, I don't know how many, 60, 70 pages. I mean, it's nuts. And so I understand fully, but I just was lucky that I was able to find them, right? And the prices that I had. But it was shocking that, you know, the plans that I think a lot of people probably are being served at, you know, currently, or, you know, through community and whatever throughout the state are that's their only opportunity, maybe.
Thanks so much, Janice. Really important to get that perspective. And I know we only have a couple minutes left. I want to pick up Jackie's question, and Judith, I think, wants to make a comment. So Jackie asked, have you considered combining these Cliff issues with working to eliminate the guaranteed issue when Medicare Advantage enrollees want to switch to traditional Medicare and can't get the Medigap they need? 4 states have regulations to prohibit this discrimination for pre-existing conditions in the purchase of a Medigap plan. Thank you, Jackie.
Yes, I know that I've heard that there are some entities that are interested in pursuing that, and I hope that would happen. That would solve one issue that could be very important to people, like when you get off of Medicaid or you get off of some other program, shouldn't you have an opportunity to make that choice then without underwriting? And if it's possible for other states to do it, it's possible for Washington to do it. Thanks, Jackie.
All right. Seems like there's a lot of work to do in this area. And Judith, do you want to take it home with a note to the group?
Sure. So absolutely, this is the joy of my heart work, by the way, as Ann knows. So definitely guarantee issue for people leaving Medicaid or a Medicare Advantage plan is a possibility. It would take a lot of advocacy and organization to make that legislation happen, but it does happen in other states. Likewise, there's a serious predicament for so there's about 1.3.5 million people on Medicare in Washington, and 14% of them are under 65, and 4% of those have end-stage renal disease Medicare and are probably on Medicaid. But the rest of them do not also have a guaranteed issue in the state of Washington to purchase a Medicare supplement. So that is another legislative idea. So I just wanted to bring up the under 65 have it the most difficult often because they have been on Social Security disability for 2 years. They're disabled. They can no longer work, and they have a very limited income, but often not some of the other chances they've had in life as older people to have saved up and have assets. So anyway, thank you for this great work, and I hope we can continue it.
For anyone that has questions or comments that we didn't get to, Ann, do you want to give your email address one more time, and a reminder to everybody that we are seeking input in the survey that Ann shared?
Yes, please do. Please email me or go onto the link and get in touch with us that way. We're excited to know more about interests of people and groups in these topics. My email address is nn@nohla.org. NoHLA stands for Northwest Health Law Advocates.
Well, thank you, Anne, and thanks to all of you for joining us today. We hope you come away with knowledge that is helpful and actionable. We will have this recording for the event available soon through our website, and I believe we'll be able to send it to all of you, right, Hafok? Anyway, you know where to find us. And please consider. Okay, great. Thank you. Thank you. And of course, it's my job to say, consider supporting NOLA's work. We engage in a range of advocacy on healthcare justice, and we greatly appreciate any donations. We also have a newsletter, which you can sign up for on our website. So thank you all, and have a good rest of your day.
Bye, everybody.